diagnostic tools. If somebody comes in, they've got a little lump or they've got a tender area, what do you do to help diagnostically?
Well, so if I have a problem, then I'm going to write an order and I'm going to schedule that patient for a diagnostic mammogram typically. Now, if the patient is young, say they're under the age of 35, sometimes the breast tissue is so dense that the mammogram, which is an x-ray of the breast, won't penetrate the breast tissue, and the breast tissue will look suspicious even though it's normal just because it's so dense. So in that circumstance, in women very young, we will typically do an ultrasound first to establish whether or not we can see any kind of mass in that area.
What's an ultrasound like? An ultrasound of the breast? What do they do?
Well, actually what they do is they take a little wand and they put a little gel on it and they actually roll it over the breast tissue. It's painless for most of my patients, and it takes a very short period of time, and it gives the radiologist a lot of information.
So it sends a sound wave that comes back, and you can look at that on an image. What is a cancer? What's he looking for?
Well, cancers actually have a special appearance in the breast tissue, and they're very different in appearance than, say, something like a cyst, which is going to look really black on the inside, or say a benign tumor like a fibroadenoma, or breast changes called fibrocystic changes. They all look very different. Cancers typically are going to be brighter and they're going to be more dense in appearance. They can have some calcifications that are characteristic. And so the radiologist can use that pretty well in somebody with denser breast tissue.
So there's a big differential diagnosis of things that can be causing something that's abnormal. That's the ultrasound. If the ultrasound says there's an area we're worried about, do you have any other imaging that you can do of a breast?
Well, so if we've got a patient who's 40 years old or older, I'm definitely going to start with a mammogram. But when you write for a diagnostic mammogram, that gives the radiologist the opportunity to do the mammogram first. And if they still need some clarification, they may add an ultrasound to that. Now, if you've got somebody that is high risk for a breast cancer, for example, somebody who's had a breast cancer before, or somebody who has a first-degree relative that had a breast cancer at a younger age, or heaven forbid somebody that actually has a breast cancer gene which increases their risk of developing breast cancer, those women then may undergo an MRI. Now, the benefit to the MRI is that it sees a whole lot. It's very, very detailed information. But unfortunately, you don't want to do that in people that are lower risk, because sometimes you see things and you're like, well, that looks suspicious, when really it's not. So it gives a lot more information, but at the same time, it's expensive and it's not really required of everybody. But it's definitely beneficial to those women who are higher risk.
So if somebody comes in, they have a suspicious area, they get an ultrasound, they get a diagnostic mammogram. Can you get with what percentage accurateness do you get when you say, looks like everything's okay right now, we want to look at it again in 6 months?
Very good chances. As a matter of fact, most of my patients' reports will come back and they will be able to say, hey, this looks fine, and we'll see you back next year. Having said that, if there is some suspicion or the patient has a high risk factor, they may get to follow up in 6 months. I rarely see less than 6 months, and typically, again, those are in individuals who have pretty high risk factors.
Yeah, everybody's different.
Yes.
Every breast is different. Every history is different.